official definition of infertility is what, 12 months of unprotected sex and the inability to conceive, right? So it's not absolute, it's within 12 months.
What is more and more certain these days is the data, both clinically and in the scientific literature and empirically, that testosterone therapy is gaining more and more popularity, backed by ever-increasing amounts of positive data. One of the concerns sometimes, though, can be, what do you do about fertility?
TRT 100% does affect your fertility.
Welcome back, everybody. It is another episode of the Vitality Code podcast. I am Dr. Jason Farrah with my esteemed, continually well-bearded, interestingly garbed brother, Dr. Jeffrey Farrah. Jeff, that's a fancy. That is
I was wondering what you were going to say.
That's a fancy outfit, my friend. What do you got?
It's amazing. It's pro-America, basically.
America.
I got this at the quintessential Bass Pro Shops. We have
that's the quintessential American store right there.
It is. We have Mount Rushmore. It was actually the Bass Pro across from the Daytona 500 racetrack.
It was. That's
a slice of Americana, baby. I got Mount Rushmore. I got bald eagles, and then I got some fighter jets spitting out the American flag.
Man, that is.
I wore this in honor of our presidential debate, which took place last night. I tell you why I'm excited. It is official. We have reached the bottom. There is nowhere else to go. We cannot go lower. This is it. This is it, folks. You're witnessing the literal bottom of the barrel. It doesn't get any worse. There are no two dumber people in America. But maybe not dumber is not the right word. Incompetent at their current state for the current job they're applying for. It doesn't get any more. I would venture to say we could just put out an ad on Indeed. Maybe Congress could float that idea, and we could take some applicants. Looking for presidential candidate to run large country. Must have decent communication skills. You will have 50 subordinates that you will have to coordinate. It was awful, man. It was hilarious.
It's one thing to have these two particular candidates squaring off and arguing over who has the better handicap at golf. If internationally everything was perfect, all our trade partners were, but that's not the case. We have a 3-year. We're now in the third year of the Ukraine war. We got Israel, Hamas. I mean, it's just like total chaos. Economic. It's the fourth turning. I don't know if you've heard that term, but it's definitely we're in the fourth turning. It's crazy. Yeah, but you know what, man? There's a lot of uncertainty and a lot of instability. But what is more and more certain these days is the data, both clinically and in the scientific literature, and empirically, that testosterone therapy is gaining more and more popularity, backed by ever-increasing amounts of positive data, both clinically, empirically, and all three, and the broader scientific literature at large, which is exciting. One of the concerns sometimes, though, can be, what do you do about fertility? I've seen recent studies. We all have seen the worldwide scourge of low testosterone as it's being more and more picked up by news and media outlets. Yeah, there's a lot of good things that testosterone can do for you, but there are, of course, things that you have to be aware of when you're seeking out these treatments and so forth. And then, of course, as a provider, when you're informing patients about side effects and, what can happen during treatment, or what, the different possibilities. Do you see this as an issue in your practice?
100%. Yeah. I mean, I think a couple things are coming to light when you talk about testosterone. Yes, I agree with you. It's getting its 15 minutes right now. It's interesting. Even in the, I haven't been doing this for 40 years or something like that, but I've been doing it for a decent amount of time. But even in the time that I've been doing, I went from being poorly viewed in the medical community, testosterone at large. Then there was this sort of, like, you could just see the landscape changing to now, like, private equity is dumping tons of money into it. I'm training clinics that are doing, 700 clinics nationwide. Businessmen are jumping on board. Primary cares are wanting to know about it, and the TikTok sphere at large. It's the next latest. Yes, Gary Brecka's dropping his knowledge bombs on us daily. Thank God for him. But
Oh my
one of the
gosh.
things that I've seen is a significant increase in awareness in my clinic of the younger and younger males in my patient base that have significantly low testosterone and are hypogonadal. TRT, I saw a stat, TRT, this was for up to 2011, so it's a bit old, but TRT had increased from a 10-year period from '01 to 11 threefold. Under
300%. Wow.
under 40, it had increased fourfold in the over 45 crowd.
Wow.
And I think that saw up 7% of men under 40 were hypogonadic, and 38% 45 and older were hypogonadic. So we're seeing a bigger and bigger increase in younger men. I'm seeing it in my clinic. It's becoming, I would say, on a weekly basis.
Hypogonadic as in the low testosterone, or hypogonadic in other definitions of the word?
Testosterone.
Okay.
Yeah, testosterone specifically. It's not uncommon anymore for me to have a guy in his 20s with a testosterone of 200. In the 200s, let me say it that way.
Recognizing
in the
we have a
200s.
selection bias, but even for us.
Correct. Yeah, I always tell people, like, I obviously you don't come into me at 25 saying, Doc, I feel amazing and I think my testosterone's low. So you're going to get a selection bias. But even as much as, I don't know, as soon as like 5 years ago, I wouldn't have said that. I saw that. It's been exponentially increasing. And so is it awareness? Is it all the things at large? Is it more testing? Or I don't know, but I'm just telling you, I see more and more of it. So I'm talking specifically to the side effects of fertility more and more and more with men. And it is twofold. I see it done poorly, and it scares me a little bit when I see these big, not scares me, it makes me concerned a little bit when I see these big chains popping up, and I wonder about practitioners doing it properly, the acceptance, social acceptance of it. Are young guys going to be doing it properly? Are they taking the steps? Are they knowledgeable of the steps that testosterone can have in impacting their fertility? So, yeah, I agree, and I think it's important to kind of know the science behind why does TRT impact your fertility. And I think a lot of guys and practitioners, frankly, don't maybe understand that fully. So, yeah, I think it's important to discuss.
So, it's interesting because it requires a mental model that involves a methodical approach to the patient with hypogonadism to look at the causes of it. And then if you're going to think about treatment, you need, I always ask after, we need to go through the different causes of it or what may be happening on a physiological or anatomical level. And then if you get to the point where you're deciding on TRT or not, you have to have that discussion. Do you desire immediate fertility? Do you desire long-term fertility? If you do, and you desire some type of TRT or or as an aside or as an alternative route, raising the testosterone in some form or fashion, what's that going to do to you long term, and what's the best way to do it under the premise of immediate fertility or long term fertility? But how do you couch the discussion, or how do you explain to folks the discussion in your basic patient about where testosterone comes from? I mean, is it get to that level in your discussion?
Yeah,
where does testosterone come from? What stimulates? And again, this is male. I think it's mostly males, and then you and I have talked about this offline. In certain ways, it's interesting when we speak about testosterone replacement in women for androgen deficiency. Not necessarily hypogonadism, is more androgen deficiency. It's a different setup. It's usually occasionally can be women of childbearing age, and fertile women, but it's usually women who have already had kids, usually, not always. Of course, a woman can still get pregnant, obviously, on testosterone therapy, and is why they have to have some form of contraception, because testosterone is a pregnancy category X, and we don't want to have virilization of a fetus, etc. But for the most part, this fertility discussion seems to be relegated to the area of men, right? Is that what you
Yes.
see mostly too?
Yes. I mean, 99.9% of my discussions um, involve that. I include it in part of my discussion. So I start out, we talk about why they're there, we sit and talk. Then we talk about their labs, and then we talk about some of the decision-making process that they'll have to go through, whether or not they decide to start this treatment. And that fertility conversation is in the pros and cons talk. So I usually draw a little guy on my wall, and I kind of where the FSH, LH, and the testosterone, why it impedes that. So I tend to do the testosterone levels, estrogen levels, CBC, CMP, FSH, LH. I don't as commonly now rely on the free testosterone and SHBG as much on the outset. I have utilized those more in the fine tuning of dosing if that becomes an issue. But when it talks about fertility, yes, I check all those levels. I don't do prolactin as a carte blanche. But I sit down and have a discussion with the guys, and I try to explain to them, at least on a superficial, I wouldn't call it even superficial, on a deep level for a patient, but on a super level for a physician, how that fertility biofeedback, that negative feedback loop works when they take testosterone, how that impedes their FSH, LH, how that then impedes their intratesticular testosterone. So I go through that algorithm with them from the outset.
And like you, I do a very similar thing. If I can't find a reason for the low T, or I suspect some kind of, through other screening mechanisms, including just clinical questions, do you have blurry vision, double vision headaches recently, those kind of things, which, the pituitary above the optic chiasm and optic nerve chiasm might have symptoms of blurry vision, etc. But outside that, it's nice to get the LH and FSH ahead of time, because it might give you a clue as to why they're having low T, and would help screen for things like use of androgenic anabolic steroids, etc. So why those things in the first place? And that goes back to your original question. Sorry for the circuitous route there, but so typically you have a pulsatile secretion of GnRH, gonadotropin releasing hormone, from the hypothalamus, and it's a cascading or waterfall effect, or a relay race, if you will, where one talks to the other, talks to the other, talks to the other. So we talk about the HPG axis, hypothalamic pituitary gonadal axis. Hypothalamus detects neurons in the hypothalamus, so brain cells, if you will, in the hypothalamus, a structure deep within the brain, is sampling the blood, and thereby is exposed to circulating androgens and estrogens, circulating testosterone and estrogen, okay? And based on those levels, can tell if we're low or high or somewhere in between. There's a trigger point, a certain signal, and then in a pulsatile fashion, GnRH, gonadotropin releasing hormone, is released from the hypothalamus, which stimulates the pituitary to release follicular stimulating hormone and luteinizing hormone. Those two hormones are carried through the bloodstream down to the testes, where they stimulate Leydig cells. And this is a very simplistic manner, by the way, and this is intended for this particular audience, and this is not a conference for urologists or fertility specialists, and nor do we claim to be either of such two specialists. But at the level of the testes, the testicles inside the scrotum, obviously part of the male anatomy, is that you will then, FSH, just grossly speaking, will stimulate the FSA, or stimulate Sertoli cells, and the Sertoli cells kind of are, responsible for releasing factors that keep up the seminiferous tubules and the kind of maturing the sperm. They're kind of the shepherd to the sheep, if you will, making the right environment right for
you just say the shepherd to the sheep
to mature, and the shepherd to the sheep, baby.
I like that. That's a good
to
one.
the young bulls. the running of the bulls. So the ejaculation is the running of the bulls. Let's. I'm losing that metaphor battle real quick. But the androgen receptors that exist on the Sertoli cells are what need to be triggered, so testosterone needs to link up to the Sertoli cells to mature the sperm. Well, that testosterone seems to come from, as best I can tell in the literature, the Leydig cells. So this population of cells that is producing androgens, intratesticular testosterone specifically, and that's what you talked about. So that's very interesting, because you could be a man with a lower or mid grade testosterone, let's say, or normal within the range, middle of the range, right? But you could still have a high intratesticular testosterone, which tends to be higher than the serum testosterone anyway. A high serum testosterone, like a lower serum testosterone, as best I can tell in literature, does not really correlate to an intratesticular testosterone. And it is the intratesticular testosterone which induces the maturation of the sperm. That comes from Leydig cells. What stimulates those is luteinizing hormone. So now, then Leydig cells will release androgens into the bloodstream as well, right? And that's why you get testosterone from your testicles. That then travels up to the hypothalamus, etc., and pituitary for negative feedback, meaning if those levels go up, the signal drops to release the different gonadotropins, those hormones that come from those deep brain structures. Likewise, estrogen. Where do we get estrogen? Well, in males, we get it from conversion of testosterone by the aromatase enzyme, specifically, or most concentrated aromatase enzyme levels are found in the fat tissue. So, interestingly, it is said or thought that the hypothalamic neurons and pituitary neurons receiving negative feedback are more sensitive to estrogen than they are testosterone. And that may be because, just through deductive reasoning, it takes quite a bit of testosterone to, spill over and convert into aromatase in the first place. And so the estrogen levels are probably a little bit more sensitive indicator of how, if you have more, or if you have too much or not enough testosterone. I guess that's it in a nutshell. Fill in the gaps for me if you see any.
No, that's good. That's what I kind of go through that same explanation with guys. I just say, when you take this and I draw kind of a circle, I have a left side and right side of the stick diagram, which I actually just draw a little guy, and I just tell them their brain communicates. I leave out the hypothalamus to pituitary, and I just kind of go from the LH, FSH signal portion, and I describe to them, you have the stimulating chemicals,
sure,
FSH and LH, that tell your testicles to spit out testosterone. And they spit out testosterone, your brain recognizes that, finds a happy medium, and that cycle just kind of goes. In addition to that, you have those signals from the brain. The FSH and LH also stimulate another form of testosterone called intratesticular testosterone that we have not measured, and we aren't privy to that information, but it is there, and that is the main hormonal control for spermatogenesis. And if we come in from an outside source and we give you testosterone, your brain will now pick that up and it will disrupt its normal signal. So therefore, your normal production of serum testosterone will drop. But we are going to continually come in and give you extra testosterone exogenously. So I always answer guys, yes, this will drop your natural production of testosterone while you're on exogenous testosterone. It will also, most likely, probably definitively, lower your intratesticular testosterone. And that is the part that we can't measure, and that is important for your spermatogenesis. Therefore, we need to have a talk about fertility. That's the quick, less scientific version of what I tell my guys, what you just explained. It kind of helps them understand, though, like, because everyone comes in and they're just like, am I going to have to stay on this? Is it going to crash my testosterone? Am I going to be infertile? And so that starts that conversation. That lays at least a basic scientific premise from which we can start to talk the nuance of it. But it does, TRT 100% does affect your fertility.
And I tell folks, I don't know how you'd frame it, but I try to make sure they know some of the details that are somewhat nuanced in a rough, generalized manner that's easy to digest, hopefully, to help them have a framework in which to make the decision. So I tell guys, and here's another thing too, just as an aside, I think as a practitioner you need to remember this, and I think it's important to kind of state it gently or just get it out there to people. Like whenever a person comes to you, if they've done androgenic anabolic steroids, or if they have a genetic malformation, or they were born with undescended testicles, or they have a dilated venous plexus, a pampiniform plexus of the testicles.
Environmental causes. Yeah. It doesn't change your genetics. Painful.
98% will recover enough to be able to conceive, right? So
Yeah,
it's not that you're structurally changing somebody. You're not genetically changing somebody. You're making them subfertile.
Yeah, do you know of any research that would say, like, how long do you have to do steroids? How much anabolics do you have to do? How much length of time on TRT or dose that makes you permanently infertile? I don't know what that number or data is. Is there? I don't think there is.
No, I know that. So I have seen studies demonstrating again that those inject. Now I've not seen anything for pellets, and pellets, I guess because they're more of a niche thing, and I don't see a lot of younger guys that are trying to conceive using pellets, although I have, or that would try to conceive. But for injectable, either subcutaneous or infertility or subfertility tends to begin 3 months after initiation under routine TRT doses. Now, a lot of this is going to be deductive reasoning because this is not a well-studied area. There's not a lot of research dollars to this, and there's a heck of a lot of bro science or kind of anecdotal evidence. So
Well, and you can't set a bunch of guys.
But as best I can tell,
You can't set up a bunch of guys that
ethics
are gonna,
of researching this are
yeah,
tough,
ethics
right?
of research. You can't just come in and say, "Hey, we're going to see if we can make you infertile from this testosterone dosing," and half of you
cool
won't.
with that? Yeah, exactly.
But I tell guys
yeah,
too.
sure, I want to sign up for that. Yeah.
I tell guys when I talk about it, and this is my experience in the clinic, I have yet to see a male on TRT dosing not be able to recover his fertility. It is a matter of how much effort and time you're going to have to put in it, how long you're going to have to be on it, how much you're going to have to reduce it, how much HCG, how much Clomid, and how much time you're going to have to use those. I have yet personally, again, small sample size, just one clinic, yet to see a guy not be able to recover sperm. Now, it is a matter of
assuming pre-morbid, yeah. Pre-therapy, they were structurally okay, genetically
Correct.
okay,
Yeah.
didn't have any LH receptor mutations, blah blah blah. Yes, and so as a rule of thumb, I'd say from 3 months of use to what I can see in the literature. Again, very limited studies, but there are studies. 3 months of use to approximately 1 year of use. For infertility begins at 3 months, takes 6 months to recover after cessation. 1 year of use to 2 years of use takes up to 12 months after cessation. 3 years of use, and there was some decent studies on testosterone undeconate, for instance. It took the literature or the study concluded several years. I can't remember the exact time, plus or minus the range, but it was multiples of years, greater than 3, to get to a level of fertility where you could impregnate somebody, and also had to use stimulatory gonadotropins like HCG or gonadotropin analogs. And I saw similar numbers. Again, there were different studies, but similar numbers for testosterone, enanthate, and cypionate. So that's my rule of thumb that I go by based on the very limited numbers. Now, in my clinic, yeah, I agree with you. What I typically see on TRT doses, not guys who are IFBB pros and on all kinds of different, AAS for long periods of time, but the general normally fertile male who pre-TRT was normally fertile, then on TRT for a routine amount of time, generally speaking, has, in my experience, been able to recover fertility to a satisfactory level. And I think that's what you're saying too, right?
Yeah, I always tell guys it's most likely a factor of how long you're on TRT and what your dosing took you if you went super physiological,
Yes.
if you added things to it. Now, I can't
Yes.
I can't really give you I can give you some parameters, but I can't really say your body on TRT for 2 years at 800 post-treatment serum levels is going to give you this type of recovery, but it lends itself to the talk that we should be mindful of how high we go and no necessity of going super physiological. If you are going to have children, and this is part of TRT and children are going to happen at the same time, we need to be aware of that on the onset, because the higher you go and the longer you're on it, there could be potential problems. I have, on a practical sense, and I know the research is what the research is. I have found there to be a lack of good research that shows what I see in the clinic. I don't. I see that with. I tell my guys, give me a 6-month on ramp of when you want to stop. I tell most people stop preventing, as I see as like the first step to trying, and I say give me 6 months to that date, and we should be pretty good on doing a stepwise recovery of fertility to give you options.
Yeah, I mean, I think again, you're right, and I have no issue with incomplete reliance or some dispersion towards the literature, because the problem is there's basis for that, and the basis is that there's very little to go on, and what there is case series, retrospective reviews, and data that's of low grade and low quality. But interestingly, the literature that does exist does support your thesis, though. I mean, and so I think, despite not relying on the literature as a whole lot, because again, there's not a lot, what little there is does seem to back you up and mirror what you're saying.
Yeah, I guess I was more speaking to like 3 years of time to recover fertility seems like quite a long time. And I'm wondering if that was just, I don't know the study you're referring to, was that just stopping testosterone and letting nature take its course, so to speak, to recover fertility, or was that including the use of Clomid or HCG?
Yeah, it's poorly defined too. No, both. But this was for people that were on long half-life Nebido, I think is the trade name, but testosterone undeconate, for a duration of greater than 3 years. I think at 500 milligrams a month, so just over 100 milligrams a week. And I don't remember the exact splits on percentages. However, at 12 months, if they were under 3 years, almost everybody, 98% recovered at 12 months without ancillaries. If they were on it over 3 years, recovery said, it may take up to several years. They classified it. There was a range there.
Without ancillaries?
And may involve the use of ancillary drugs to stimulate. No, may involve it. So I can't remember the exact splits.
Sure.
So that's a very vague answer. And that's because I haven't memorized the data in exquisite detail, although it was somewhat vague, the data.
I recommend my guys, sorry to interrupt you there, but I recommend my guys always use ancillaries. Like, don't just cold turkey stop and then try to recover your testosterone that way. It doesn't seem to be an ideal situation or an ideal protocol.
Not to do. I can't. Yeah, I agree. I exactly, for fertility and for your well-being, both metabolically, cardiovascular, mentally, physiologically. And so I tell guys too, don't some things too, I think it's important to have context. And so Jeff, one of the unique situations here is that I've gone through this as a TRT patient who then conceived children after initiating TRT for hypogonadism. So I have that. It's somewhat tough because I have a bias. It can lend to a bias, and I admit that. If you've gone through it yourself, but it also gives you a unique insider's perspective too. One thing to realize is that a normally fertile man, a normally fertile woman, so a normally fertile couple have roughly, I've seen 25%, I've seen a third, so I'll say roughly 25 to 30% or 33% chance of conceiving with routine intercourse if you break up the time frame in the woman's menstrual cycle. So that's per menstrual cycle, 25 to 33% chance. And I tell people you have to make it a job. You have so much sex, you got to have. You need to make it a job. So
I like how you call the routine. Is that what your wife calls it? The routine.
AKA, it's a mission. Yeah. No,
yes,
routine or regular. Just in the sense of regular.
Yes,
but
I know.
It
was just a funny term.
Oh my gosh. If you ever thought women's libido couldn't match a guy's, just give them a purpose. When they go on a mission to have a baby, it's Man, it's lights out. I mean, it's like heat-sinking missile, right? You know, it's like
You're getting
locked
text messages
on,
at lunch.
target. Better be ready.
My app, my phone app, my whatever, my finger stick, my thing that I'm testing every single day, my temperature, it's at this, that, and the other. You be here in 10 minutes. You're like, oh, jeez.
It says 4 hearts or whatever, the 4 flames or whatever. Like, max or the
max ovulation has been reached.
Was ultrasounding her ovaries because she, yeah.
Wow.
Commence intercourse. But yeah, she was ultrasounding her ovaries. She was on OB rotation, but so I think its context is important. Then you can say too, don't forget, people with oligospermia can still conceive, right? The numbers I saw from the World Health Organization were like 23% can conceive at 2 years, 33% at 4 years. I think there was another number there. Anyway, but even people with down as low as 2 to 5 million sperm per milliliter can do it. I mean, those reports.
Right. I mean, I guess the official definition of infertility. The official definition of infertility is what, 12 months of unprotected sex and the inability to conceive, right? So it's not absolute; it's within 12 months. So that technical term means within a time frame
of routine intercourse.
Routine. So let's
give me the bullet points here.
Yeah, no, I was gonna say go ahead and shoot. I was gonna say we need to maybe come back and visit the testing that you may have a young guy come through. Let's talk about some of the protocols. I think that deserves a deeper dive. Some of the actual protocols we're using in the clinic, because I have found there to be a lack of great protocols to follow. But as a sort of wrap up to this, 100% I would say, and I think you would concur, that this is a form of is a concern to be addressed. It does affect your fertility. I tell people we don't just get scared of things. We don't ignore things. We don't go to the extremes, but we address them and we lay out a game plan, and that's usually the best way to address something like fertility while on TRT.
Yeah. So in conclusion, is fertility a concern? Yes, but that answer is not black and white. It is initially, right? Yes, it's a concern. Now, sit down, strap in. We're going to talk about it because it's going to take a little bit to explain the subtle nuances. Here's the science of negative feedback inhibition of the hypothalamic pituitary gonadal axis. And again, like you're right, we don't have to go into the extreme detail, but just to break it down for patients so they can understand and have a little context. And then context of fertility in general. And then a brief discussion maybe on what it means to be fertile or not fertile, and then what you can expect on TRT and what you have to watch out for, where the pitfalls are, and how we can guide you around them or through them. For instance, like one small thing would be, is it a concern on TRT? Yes, it is, but TRT isn't just exogenous testosterone administration. It may be administration of SERMs, i.e. clomiphene, to stimulate increased natural production of testosterone, which would spare or preserve immediate fertility whilst raising your natural endogenous testosterone levels. So again, is it a concern? Yes. There's a more subtle, nuanced question or a discussion that must be carried out for the patient's benefit thereafter. So I think I know we're running out of time here, but hopefully we can get into the subtle, a little bit more a deeper dive on further episodes.
Sounds good. Go America.
All right, man. Go America. Fighter jets, apple pie, Mount Rushmore, and bald eagles. Woo! Hey, man, it was good to see you.